diseases of the lacrimal gland. First, we'll see dacryoadenitis. Dacryoadenitis is the inflammation of the lacrimal gland. It can be acute or chronic. First, we'll see acute dacryoadenitis. Acute dacryoadenitis usually accompanies a systemic disease like mumps, influenza, glandular fever. It is characterized by local acute pain, swelling, tenderness, drooping of the outer part of the upper lid with characteristic S-shaped curve. It is usually self-limiting. Antibiotic with local hot compress may be required in some cases. You can see in this picture there is swelling and drooping of the upper eyelid. There is characteristic S-shaped curve. Okay, this is a case of acute dacryoadenitis. Next is the chronic dacryoadenitis. It is a proliferative inflammation of the lacrimal gland. It may be a part of the generalized granulomatous disorders, and it presents as a painless, firm, mobile swelling of the lacrimal gland. You can see this is the picture of chronic dacryoadenitis. Both eyes are involved. Next, Mikulicz syndrome. It is characterized by symmetrical swelling of the lacrimal gland and salivary gland. It may occur as a part of sarcoidosis, Hodgkin lymphoma, and one of the leukemias. You can see in this picture there is swelling in the lacrimal gland as well as parotid gland. It's a case of Mikulicz syndrome. Dacryops. Dacryops is a cystic swelling in the upper fornix due to retention of the secretion owing to the blockage of one of the lacrimal duct. Surgical excision or marsupialization of the retention cyst by a conjunctival root is the treatment. You can see there is a cystic swelling in the fornix. It's a case of dacryops. Lacrimal gland tumors, relatively rare, show a marked resemblance to the parotid gland tumors. It present in the middle age, progress slowly until they become palpable as hard, nodular, or slightly mobile lumps. Proptosis occur in downward and medially, along with limitation of the movements and the diplopia. You can see in this picture, eyeball is directed downward and medially due to the lacrimal gland tumor. This is the lacrimal gland tumor. Benign mixed tumor form a majority of the cases and have an excellent prognosis. Carcinomas have more rapid onset, often with pain and lymph node involvement. A biopsy may be needed to confirm the diagnosis. If malignant, radical surgical removal or full extension of the orbit is advisable. Now we'll come to canaliculitis. Canaliculitis is the inflammation of the canaliculi. It may be acute, chronic. Acute canaliculitis is usually due to herpes simplex infection and is self-limiting. And chronic canaliculitis is most commonly caused by actinomyces. Discharge, spouting punctum, concretion within the canaliculi are features. You can see in this picture, this is the punctum. Surrounding structures are inflamed with pouting of the punctum. This is a case of canaliculitis. It also causes stone formation in the lacrimal sac. Aggressive foreign body sensation during probing establishes the diagnosis. Treatment is by linear incision in the conjunctival side of the canaliculus. Next is occlusion of the puncta and canaliculus. Causes it can be congenital closure or maldevelopment, foreign body or concretions, then scarring due to burn, cosmetic, trauma, infection like trachoma, herpes simplex. Then certain medication also cause punctal stenosis and all. These drugs are IDU, idoxuridine, phospholene iodide, 5-fluorouracil. Slit lamp examination is important for diagnosis. So treatment is removal of the foreign body or by dilating the canaliculus and slitting it with a canaliculus knife. In case of canalicular block, conjunctival, dacryocystorhinostomy with bypass tube is the treatment. Now we'll come to dacryocystitis. This is very important. It may occur in two forms, congenital and adult dacryocystitis. First, we'll see congenital dacryocystitis. It is also known as dacryocystitis neonatorum. It is the inflammation of the lacrimal sac occurring in the newborn. You can see in this picture there is swelling in the lacrimal sac area. This is a case of congenital dacryocystitis. It follows stasis of secretion in the lacrimal sac due to the blockage in the nasolacrimal duct. It is a very common occurrence, about 30%. Most common cause is the membranous occlusion at the lower end. Other causes include presence of epithelial debris, membranous occlusion at the upper end near the lacrimal sac, complete non-canalization, or bony occlusion. Associated common bacteria are staphylococci, pneumococci, streptococci. Clinical feature, it usually present as a mild-grade chronic inflammation. Epiphora is the main symptom. It usually develops after 7 days of birth and is followed by copious mucopurulent discharge from the eye. Regurgitation test will be positive. When you press in the lacrimal sac area, there will be regurgitation of the mucopurulent discharge from the lower punctum. And there will be swelling in the lacrimal sac area. Differential diagnosis include ophthalmic neonatal, then congenital glaucoma. In ophthalmic neonatal, patient will complain of discharge, there will be marked edema of the upper eyelid, then congenital chemosis will be there. In congenital glaucoma, you will have patient will complain of epiphora, photophobia, blepharospasm, buphthalmos. Okay. Then complication, it may be conjunctivitis, dacryocystitis, lacrimal abscess, fistula formation. Treatment massage over the lacrimal sac area with topical antibiotics. When you do massage, increases the pressure in the lacrimal sac area that helps to open the membranous obstruction. Lacrimal syringing with normal saline or antibiotic solution. Lacrimal syringing also increases hydraulic pressure inside the lacrimal sac. Then third is the probing of the nasolacrimal duct with Bowman's probe. Then balloon catheter dilatation, intubation with silicone tube, dacryocysto-rhinostomy operations. Then we'll see adult dacryocystitis. It may be acute or chronic. Chronic is more common than acute dacryocystitis. Etiology, it can be multifactorial. There is a vicious cycle of stasis and mild infection of lacrimal sac. Predisposing factors, this is a very important disease in viva. First is the age. It is more common between 40 and 60 years of age. In sex, it is more common in female due to the narrow lumen of the bony canals. Then race. It is rare among the Negroes as nasolacrimal duct is shorter, wider, and less sinus. Hereditary also plays an important role. It affects the facial configuration and also the length and the width of the bony canal. It is more common in the low socioeconomic group, and poor personal hygiene is also another important predisposing factors. Now we'll see factors responsible for stasis of tear in the lacrimal sac. First is the anatomical factors like narrow bony canal, partial canalization of the membranous nasolacrimal duct, excessive membranous fall in the nasolacrimal duct. Or it can be due to the foreign body in the sac. Then excessive lacrimation also causes stagnation of the tear in the sac. Then mild-grade inflammation of the lacrimal sac may block the nasolacrimal duct by epithelial debris and the mucous plug. Then obstruction of the lower end of the nasolacrimal duct by nasal disease like polyp, DNS, tumors, atrophic rhinitis. Then sources of infection may be from the surrounding structure like conjunctiva, nasal cavity, paranasal sinus. Causative organism includes staphylococci, pneumococci, streptococci, pseudomonas, pathogens. Tuberculosis, syphilis, leprosy are rare. Clinical feature, it is divided into 4 stages. First is the chronic catarrhal dacryocystitis. It is characterized by mild inflammation of the lacrimal sac associated with blockage of the nasolacrimal duct. Here, patient will complain of watering eye, mild redness in the inner canthus. On syringing, you will get clear fluid or fibrous mucus flake from the punctum. The cryocystography revealed block in the nasolacrimal duct and normal sized lacrimal sac with healthy mucosa. You can see in this picture there is mild inflammation in the lacrimal sac area. The second is the stage of the lacrimal mucosa. It follows chronic stagnation causing distension of the lacrimal sac. Its characteristic features include constant epiphora, swelling just below the inner canthus. You can see in this picture there is a swelling in the lacrimal sac area just below the inner canthus. Regurgitation test: milky or gelatinous mucoid fluid regurgitated from the lower punctum on pressing the swelling. Then the cryocystography revealed distended lacrimal sac with blockage in the nasolacrimal duct. In cystic mucosa, it occurs due to continued chronic inflammation. Opening of both the canaliculi into lacrimal sacs are blocked, so there will be large plexual swelling in the inner canthus. And when you do regurgitation test, it will be negative. Then stage of the chronic suppurative dacryocystitis. It occurs due to the pyogenic infection. Mucous discharge become purulent, converting the mucosal into pyocele. Characterized by epiphora, recurrent conjunctivitis, swelling at the inner canthus with mild erythema of the overlying skin. On regurgitation, a frank purulent discharge flows from the lower punctum. If openings of the canaliculi are blocked, insisted pyocele result. You can see in this picture there's a swelling in the lacrimal sac area. The pus point is also visible here. Then the last stage is the stage of chronic fibrotic sac. Low-grade repeated infection results in small fibrotic sac due to thickening of the mucosa. It is often associated with epiphora and discharge. The cryocystography revealed very small sac with irregular folds in the mucosa. Complication: it can be conjunctivitis, dacryocystitis, ectropion, corneal ulcer. Okay. Then there is a high risk of developing endophthalmitis if intraocular surgery is performed in the presence of dacryocystitis. That is why we are doing syringing before any intraocular surgery in order to just to rule out this dacryocystitis. Treatment: conservative treatment by probing lacrimal syringing, balloon catheter dilatation. It is done in a patient with partial nasolacrimal duct obstruction. DCR, dacryocystoRhinostomy, it is the operation of choice as it re-establishes the lacrimal drainage. Before performing surgery, infection should be controlled. DCT, it is performed only when DCR is contraindicated. We'll see some indicators of DCT. First is 2 or more than 60 years old patients, markedly shrunken fibrosac, tuberculosis, syphilis, leprosy, mycotic infection of the sac, tumors of the sac, gross nasal disease like atrophic rhinitis, or unskilled surgeon. Then conjunctival dacryocystoRhinostomy, it is performed in the presence of blocked canaliculi. Now we'll come to acute dacryocystitis. It is an acute suppurative inflammation of the lacrimal sac. It is characterized by presence of painful swelling in the lacrimal sac area. Etiology: it occurs as an acute exacerbation of the chronic dacryocystitis or as an acute peridacryocystitis due to the involvement of the surrounding structures. Causative organisms are Streptococcus, Pneumococcus, Staphylococcus. Clinical features are divided into 3 stages. First is the stage of the cellulitis. It is characterized by painful swelling on the lacrimal sac region. It is associated with epiphora and constitutional symptoms like fever, malaise. Then swelling is red, hot, firm, and tender. Redness, edema also spread to the cheek and lid. Then second is the lacrimal abscess. It occurs due to continued inflammation. it causes occlusion of the canaliculi due to edema. So the sac is filled with pus, become distended, and abscess is formed. It usually points below and to the outer side of the lacrimal sac. Then last is the stage of the fistula formation. When lacrimal abscess is left unattended, it discharges spontaneously, leaving an external fistula below the medial palpebral ligament. You can see in this picture. First is the stage of cellulitis. There is inflammation. It spread to the lower lid and cheek. Second is the lacrimal abscess. You can see pus point is here. Third is the stage of the fistula formation.
I just scrolling from this one.
There's a fistula here. Now complication: acute conjunctivitis, corneal abrasion, lid abscess, osteomyelitis, orbital cellulitis, facial cellulitis. Then during treatment is during the cellulitis stage, it consists of systemic antibiotic, topical antibiotic to control infection, then systemic anti-inflammatory analgesic drugs, and you can advise hot fermentation. Then during the stage of lacrimal abscess, in addition to the above treatment, you can do incision and drainage. Then dressing is done with betadine shock roll gauze. Depending upon the condition of the lacrimal sac, you can do DCT or DCR. Then treatment of the external lacrimal fistula, fistulectomy along with DCT or DCR operation should be performed. Then we'll see DCR operation. It performs by conventional external approach or endonasal DCR or endocanalicular laser DCR. We'll see only conventional external DCR. First is anesthesia. General anesthesia is preferred, but you can do under local anesthesia also. Then skin incision, a curve or straight incision about 8 mm from the medial canthus is made. You can see in this picture, you can make a curve or a straight incision about 8 mm from the medial canthus. Then second is the exposure of the medial palpebral ligament, anterior lacrimal crest. Then dissection of the lacrimal sac. Periosteum is separated from the anterior lacrimal crest, and lacrimal sac is reflected laterally with blunt dissection, exposing the lacrimal fossa. You see in this picture, this blue color represents the lacrimal sac, and this yellow color represents the lacrimal fossa. Okay. Then next step is the exposure of the nasal mucosa. About 15 to 10 mm bony ostium is made by removing the anterior lacrimal crest and bone forming the lacrimal fossa. Then thick pinkish white nasal mucosa is exposed. You can see here this white bluish color structure is the lacrimal sac, and you have already made a bony ostium here. So this pinkish structure is the nasal mucosa. Next is the preparation of the flap of the sac. A probe is introduced into the sac through lower canaliculus just to identify the lacrimal sac. Then sac is incised vertically to prepare the anterior and posterior flap, and incision is converted into H shape. So you have made here incision, vertical incision in the lacrimal sac as well as in the nasal mucosa. Now suturing of the flap. Posterior flap of the nasal mucosa is sutured with posterior flap of the lacrimal sac using 6-0 vicryl, and is followed by suturing of the anterior flap. You can see in this picture, this is the posterior flap of the lacrimal sac, and this one is the posterior flap of the nasal mucosa. Posterior flaps are sutured here, only anterior flap is left. You can see in this picture the anterior flap also sutured. Then closure. Medial palpebral ligament is sutured to the periosteum. Orbicularis oculi muscle is sutured with 6-0 vicryl, and the skin is closed with Marcel's 6-0. Then surgical technique of dacryocystitis DCT. Step 1 to 4 are same as the external DCR, that is up to exposure of the lacrimal sac. Then after exposing the lacrimal sac, next step is the removal of the lacrimal sac. Sac is separated from the surrounding structure by blunt following a cutting edge from connection from the canaliculi. Then with artery forceps, sac is twisted 3 to 4 times to tear it away from the nasolacrimal duct. Then curettage of the bony nasolacrimal duct just to remove the infected part of the membranous nasolacrimal duct. Then closure of the wound. We'll see some this one a difference between external DCR and endoscopic DCR. So disadvantages of the external DCRs are cutaneous scar, more bleeding, injury to the adjacent structures, more operating time, significant post-operative morbidity, then no visualization of the nose. These are disadvantages of the external DCR. But advantages is more success rate, easily performed, and cheap instrument. In endoscopic DCR, there is no scar formation, less bleeding, less chances of injury, less time consuming, no post-operative morbidity, better visualization of the nasal pathology. These are the advantages, but disadvantages are less success rate than require skilled ophthalmologists and expensive instruments are required. Thank you.